Welcome to We Are Valley, a podcast by Valley Medical Center, located in Renton, Washington. We Are Valley is dedicated to providing you bite-sized advice to improve your health and well-being, and keep you updated on the latest medical guidance. This podcast is for informational purposes only and is not intended to be taken as medical advice. So please talk to your provider before making changes that will affect your health.
Hello and welcome to the We Are Valley podcast. My name's Kristen Bidwell and I am one of the podcast hosts. And today I am excited to talk about Valley's emergency department and level 3 trauma center. So one of the busiest areas and epicenter of some of the work that we do here at Valley. With me today are Kate Bendickson, our trauma services coordinator, and Dr. Cameron Buck, our medical director of our emergency department. And I'd love for you to introduce yourselves and share a little bit about your background.
Well, thank you, Kristen. I'm glad to be here and have the opportunity to talk about trauma care in the region and specifically at Valley Medical Center. I am currently the ED Medical Director and Department Chief for Emergency Services at Valley Medical Center, and I've been at Valley for about 25 years. And as part of that work, I help direct and lead our teams in a variety of situations, and the one we're talking about today is trauma. Trauma care at Valley involves a lot of persons and team members, and we are part of the state's trauma systems of care, which we will be talking on later.
My name is Kate Bendickson, and I'm the trauma program coordinator at Valley. I have been at Valley for 14 years now. Many of that was spent as an ED nurse on the floor. I took over this trauma position, which has just been amazing.
Fantastic. A lot of years of experience between you two. I'm really excited to get into more about what you do. Let's talk about why someone might end up in our emergency department and what kinds of services you provide for a range of different patients.
At Valley Medical Center, the number one mechanism for our patients are falls. But on a daily basis, we see people who sustain injuries from motor vehicle crash, work-related injuries. Some of the more common ones that we see, orthopedic trauma, so broken bones, hand injuries, lacerations. Some of the more significant or higher complexity injuries are traumas to the chest, the head, or the abdomen that require additional assessments and sometimes multiple team members. Less common ones that we see involve injuries from penetrating wounds, such as stab wounds or gunshot wounds. The injuries may involve an isolated part of the body or may involve multiple parts of the body. Any trauma system in the state of Washington or trauma center is generally equipped to start the initial evaluation and assessment and care for those types of injuries.
That is a lot. Really impressive. I'm curious, having a level 3 trauma center is a point of pride for Valley. For the average person, what does that mean? What is a level 3 trauma center and what capabilities are we required to have?
So we have the distinguished title as being one of the busiest level 3 trauma centers in Washington State for the Department of Health. So the different levels denote what a hospital has to offer, and they have time goals that they have to hit that are set by also the Department of Health. So for example, as a level 3, we have to have an OR team on site within 30 minutes, day or night. Whereas a level 1 hospital like Harborview has to have an OR team that stays in the hospital and has to be ready much sooner. We are one of several level 3 hospitals. The only level 1 hospital for many states is Harborview.
And your team has been really busy recently because we have an entire trauma program here at Valley, which we kind of alluded to, and you received a redesignation through Washington's Department of Health. So what does that designation process look like, and what standards are you required to meet?
Every 3 years, we have to redesignate. All hospitals do in the state of Washington. This consists of a huge application. It's like 500 pages. And there's a site visit by the Department of Health for level 3 and above. So my job is to make sure that all the departments are talking and they're meeting their goals, some internal goals and some external goals set by the state. And it also includes outreach to the community, which is one of my favorite things to do as a trauma program coordinator. And I have to do chart audits, and we have to enter cases into the state database that meets the Trauma Department of Health requirements. And then we're always constantly reviewing ways to better patient outcome and patient care.
Dr. Buck touched on a number of things that may bring someone to our ED and specifically in trauma, but are there other types of cases that you wanted to talk about that would be considered trauma? Or, when someone walks into our waiting room, how do you determine if it's a trauma case or not?
So like Dr. Buck said, the number one trauma mechanism of injury is actually falls. The highest population of those are by seniors. So when you hear trauma, people automatically think gunshot wounds and car crashes. And while those are trauma, it's not the majority of what we see. Even though the ground level falls by seniors seems like a pretty low mechanism or pretty low way to get injured, this population can see really, really big injuries. And then this is followed that our number two mechanism is car crashes.
I would add that in general, trauma care doesn't just involve assessing the acute injuries or deciding on what CT scans to do, but it also involves a approach to trauma-informed care. And sometimes the trauma is physical, and then there are other associated factors that can be psychological or social. And so I think any system or team tries to at least address those the best that we can. And we realize that a lot of these are unanticipated traumas and involve, I think, secondary trauma or healing phases. And so approaching that and at least trying to recognize that, whether it's an assault or an unanticipated motor vehicle crash or involves healing, I think those are the phases of trauma that are a little bit more difficult, I think, to address, but we certainly recognize that and teach our teams about trauma-informed care whenever we can.
Thank you, Dr. Buck. I'm glad you brought that up. Trauma can be physical and both emotional.
We, like many institutions and all trauma centers, attest to a framework that recognizes the impact of trauma on individuals, families, and friends, and that we aim to at least support an environment that is safe, supportive, and trauma sensitive during the care and follow-up for injured individuals.
Yeah, that's really important. We were just talking about how sometimes when people meet you, it's one of the worst days of their lives. And it's not just always because of the physical injury. And it's a great reminder about how our mission focuses us to care for our community like family in all of these areas and in different ways they're impacted. So you all care for a lot of patients in the ED and level 3 trauma center. And the latest number I have from you is about 240 a day. And you're one of the busiest level 3 trauma centers in the state. So how do your teams balance those sheer volumes of people with our high standards for safety and quality care?
Yes, thank you, Kristen. I would echo your comments as it relates to the volume. We are a level 3 trauma center, and as Kate alluded, we are part of the Washington State's trauma systems and care. And the region that we're in, the central region, has other level 3 trauma centers. For us, we have to take care of all the patients in a certain fashion, not just trauma care patients. So to your point or question of how do we do that? Well, it's, I think, years of training. It's good teamwork. It's communication. It's realizing that we have at times, sometimes limited resources as relates to a number of beds and ability to take care of patients all at the same time can be challenging when there are surges. So what we do is we continually evaluate our processes. We support standard work as it relates to triaging the sickest or the highest acuity first. And we leverage the resources that we have to the sickest patients or the patients that have generally the most time-sensitive situations or conditions.
Communication is key, and not just inside our hospital, from triage to the ambulance bay to what's happening in the zones, but then outside of our hospital too, as part of the central region and with ambulances, and then as part of the state.
I think another important element of any care team or process is continually measuring your performance, reviewing opportunities. And so as part of a trauma program in the state of Washington, we have a quality assessment process where we review certain patient populations. We review how we utilize resources in those patients, we review their outcomes, and we review the care as it relates to the time of care and how we dealt with those patient injuries. So the take home is, while we're not perfect, we always look for opportunities to improve based on measurement and system assessment.
That's really important work. You mentioned a couple times the Washington State Trauma Systems of Care. I'm curious if I think both of you, your work incorporates work with people outside of Valley as part of a larger system. Can you share more about what the Washington State Trauma Systems of Care is and how Valley fits within?
The state of Washington, and specifically the DOH, is in charge of or governs our trauma systems of care, and that involves many people working across the system. At its root is the trauma centers or the hospitals. And as Kate alluded, the department designates 5 levels of acute care trauma services and 3 levels of pediatric acute care trauma services. What I want people to understand is, while these hospitals are across different geographic regions and represent different systems, they come together at the state level to share work and collaborate.
That's awesome to know all of that work is happening behind the scenes to try to take care of people as well and as quickly as we can. I wanted to go back a little bit to when someone arrives at our emergency department, and you've talked a lot about various reasons why someone might show up and complexities of some of the cases that you see. How do you determine how someone is seen? I know we talk about the triage process, but I'm not sure if everyone knows exactly what that is. So can you explain what that looks like?
So when a patient comes into the ER, and this is not just trauma specific, they are registered with our hospitals. There's a registration person that sees them and creates them a patient visit. And then we get their chief complaint. So whether that's, cold, flu, fevers, a fall, and then they're seen by the triage nurse. And this is one of our very skilled nurses who gets a patient's vitals, that would be blood pressure, pulse, and looks at that, and then tries to talk to the patient about what happened, what brings them in, what's changed. And so by collecting all of that different data, we look and we then figure out which patients are more injured or sicker that might have to go back. Some things you can't see, like a heart attack. Some people might be a little bit more prone to that, where somebody has like a scratch or something on their leg that you can see. So there's a lot of different variables, but we have some really good people in triage. And then based on what beds we have in the back, we bring people back that are maybe the sickest or the most injured between the front triage. And then we have a triage in the back with the ambulance bay as well that a lot of people don't know about.
Exactly, Kate. And I might add that the triage process can sometimes take seconds or minutes before we determine that someone needs care and or immediate attention. A triage process might take many minutes and be completed, and then that patient has to wait to some degree before the resource or the room is available, and due to the fact that there are other higher acuity patients that go before them. So in a trauma patient, some patients come by ambulance and we can quickly triage them and identify that they are higher acuity and proceed to room them and start care, including pain control and imaging. Other patients might come in through the lobby and, as Kate said, get registered and start a quick triage process. Some of those might get roomed very quickly because they have a significant hand injury that's bleeding and we need to address that limb injury. Others, including assaults or gunshot wounds that occasionally occur, are going to be generally rapidly triaged and brought to a room more quickly. So the triage process is standard across many patients, but it can be very quickly a quick eyes on or sometimes take a little bit longer. And we also in the ED, we describe triage as not necessarily a place, but a process. And so we are sometimes re-triaging patients based on new information as they move through the system.
Really interesting. And that actually segues really well into my next question. What is a full trauma activation? So what does that look like when that happens at Valley?
We at Valley have a 2-tiered system. We have a modified trauma activation and then a full trauma activation. A modified trauma activation, usually if patients might meet some sort of high mechanism of injury for trauma. Some different aspects of a car accident can do that. A fall from a certain height can do that. The ED physicians might decide to do a activated trauma, and that speeds up imaging and labs to help identify patients that can be really injured. A full trauma activation is for those patients that have been traumatically injured at a more significant level. So this would be, we are also looking at their vitals. So they have blood pressures that are extremely low with trauma mechanism. If they aren't breathing right, there's different things that would be that. And those patients, it's usually focused more on needing to go to the OR because they're so injured. We speed up, and then the patients, they're usually either going to be transferred out to Harborview or go right to our OR.
And just to clarify, OR is operating room, right? So those patients go right into surgery. And Dr. Buck, you were going to add?
Exactly, Kate, and thank you, Kristen. What I want the audience to know is our trauma system, and specifically being a level 3 trauma system, we attest to and follow policies and procedures. Every trauma center across this country has a process as it relates to a trauma team activation, whether it be full or modified. And this really is governing and helping coordinate a rapid response of many personnel to assess, treat, and ultimately stabilize a traumatically injured patient. And so using these guidelines and workflows help at least direct the multidisciplinary approach to any interventions or things that we need to do in the ER to optimize care for the trauma patient. And so the full trauma activation gets a lot of people to the bedside quickly, a lot of resources, because those patients are identified as high risk, the ones that are most likely going to require need for an intervention, treatment immediately in the ED, treatment in the operating room to stop bleeding or correct injury, or potentially transfer to a higher level of care.
Are there additional resources that a trauma patient may often or sometimes require on top of what another more typical patient might have?
Usually a trauma patient, of course, is going to get triage. They're going to get an ED physician. They're usually going to get some sort of x-ray or some sort of CAT scan. Labs will be drawn as well. And like I said, if it's a modified or full, the results will be sped up. It's not as likely, but more of a full trauma. They will see the acute care surgeon possibly. They may receive blood products with the intent of possibly going to the operating room.
Every hospital that's a trauma center has defined resources that it relies on. And the higher the level of trauma center, the more resources and or stakeholders that are involved in delivering that trauma care. A level 3 trauma center, and specifically Valley Medical Center, has several specialists on call that can deal with specific trauma injuries. We don't have every specialist there is all the time, but we have a wide breadth of specialists, whether it be orthopedic, hand, plastic surgery, and urologic specialists, and others that can help us address and make decisions on injured patients, period. The other thing that we have is we are in a region that is connected to a level 1 trauma center. And we know that we have certain capabilities at the level 1 trauma center that we don't have here. And so we have processes to move or transfer patients when they require a higher level of care and other specialists that are unique to a level 1 trauma center. And furthermore, there's other team members that are important. Social workers help with discharge disposition. And what I would say is after hospital care and follow-up. I don't want to leave those persons out because they're important, I think, in providing the full gamut of trauma care, which sometimes may include rehab and a series of follow-up.
Yeah, absolutely. I think your work is the initial, and it doesn't happen in a vacuum. And there's so many other teams at Valley or within the local healthcare system that help to keep everybody safe and healthy. So I think that's really incredible. Well, you both have been doing this for a really long time, like we discussed, and I am assuming you've probably seen a very wide range of situations in your time in emergency medicine. Do you have any unique stories from your time in the ED or any unusual cases that have stuck with you?
Any person that works in the emergency department, physician, nurses, other team members can certainly point to cases in the past that have been memorable. I think some of the things that stick out are injuries where the human body gets impaled with objects. And so we've certainly seen those, whether it's parts of car structures or trees that get impaled into the body and they present with a very visually significant injury. And it's evident that you have to recruit a lot of resources to take care and stabilize those patients. I think what's most relevant or that comes to mind for me and some of my other team members is just the variation that we see with high risk or high impact injuries. We see memorable cases where someone is involved in a high speed injury. So the forces are high, they're going at a high rate of speed. It might involve a motor vehicle or a motorcycle. They get separated or there's rollover. Some of those patients will come in and have multiple injuries of the head, chest, and abdomen, and it usually means there's bleeding into body cavities, and they might be developing some shock from the bleeding, and they require a lot of resources, and you identify multiple significant injuries. And those tend to be very memorable because they require immediate resources. They have evidence of the bleeding on imaging, whether it be ultrasound or CT, and team members realize their value and how they approach and stabilize and recruit resources and care for those patients. What's interesting, though, is sometimes you'll see a similar patient who is involved in a high-speed collision or injury or mechanism, and they'll come in and you'll have the same concern to some degree. However, when you do your workup and evaluation, you don't always find significant injuries. And so by contrasting those two patients, you can see how our team members on one hand will do a lot of the same initial workup, but on one patient it's much more memorable and you have to do more. On another patient, fortunately, the injuries that might be predicted are not proven, and those patients are fortunate. And oftentimes it's just circumstance, but sometimes it's due to prevention, wearing helmets, obviously, and the way our motor vehicles are built now are much safer than they used to be.
Motorcycle helmets and leathers, I've seen people walk away from high mechanism of injuries that should have produced more injuries on the patient with just something like a fractured wrist, wearing full leathers and a motorcycle helmet. Another thing that's very memorable, of course, anytime we have to take care of children, that can be really hard to do. So it's children falling out of windows. That happens a lot. Screens, they think it's going to hold them in and they go to push against the screen, put their weight in, and unfortunately they fall. So that's another one that really hits the team.
Yeah, great reminders. And on the topic of children, I would say that not only do your teams have great skill, they also have great heart. And I know I've seen some stories of just how they made a really difficult moment for families a little bit easier by really caring for them and their well-being.
Another thing that comes to mind is seasonal injuries, and particularly when it's warmer weather or you have the summer events like July 4th celebrations, you are going to see extremity injuries. And so I think every ED physician or ED nurse can certainly look back and remember extremity injuries where you have hands or limbs that are damaged, amputated, or certainly significantly injured from firework or explosives devices going off. And so just a reminder to the community to be safe during those types of seasons, whether it be July 4th celebrations, being out in the environment, hiking, or on our waters, enjoying recreational activities.
Speaking of kind of flashy type cases, I have been watching the new show, The Pit. I was curious if either of you have watched it. Please, no spoilers. If you have, if there's anything, if it compares to real life, or if there's a medical show that you've seen that feels like it gets it right.
Kristen, this is a very wonderful question. I have not seen The Pit yet. That is on my to watch list of stuff, but I do know I was working at Harborview when Grey's Anatomy was really popular, and I watched Grey's Anatomy, and I remember seeing there was a patient who was in and needed labs drawn, and we were waiting on the results for labs. And the patient came to me and said, I've been waiting here for an hour for my results. And it was a very busy night, unfortunately. And the patient said, I've seen Grey's Anatomy. Everything happens within an hour from arrival to discharge. And so I had to very nicely remind the patient that a lot of other things happen behind the scenes that are not captured on Grey's Anatomy. And the actual time can take a lot longer. So that's just one that comes to me.
How about you, Dr. Buck? Any medical dramas that you enjoy?
No, I think there's value in some balanced reality versus fictional nature to all of the ER dramas that have been developed and had some level of success. over the past several decades. I'm still a big fan of MASH, to be honest with you. But as it relates to the pit, yeah, I mean, I think it has a large audience, and it is a revival of ER drama. And I think it has some great elements, specifically being kind of outlining what it's like to be in an ER for several hours or over one shift. And it has components of ERs being overwhelmed. I think what it does is it collapses a whole bunch of ER care into a short period of time. And most ERs don't do that type of degree. But I think there's some real-time formatting and value and reality to that show, balanced with obviously a fictional setting.
Good to know that it's not completely off base, so I feel like I'm learning something.
And I think Noah Wiley is a great actor, so I think that show definitely is on my list of shows that I watch and appreciate.
Awesome. So what advice would you both give to people in our community to try to avoid a trip to come and see you in the emergency department and level 3 trauma center? Are there any injuries or traumas that you see that have an element that could be prevented?
Yeah, thanks, Kristen, for asking that question. I think many people understand that there's primary prevention and preventing trauma, injury, or exposure. Some things that I would highlight related to safety measures: wear your seatbelt, wear a bike helmet if you are riding a bike or a skateboard or another motorized device. Additionally, a big issue, or at least thing that I want to highlight, is distracted driving. Put your phone down, use other means to communicate, or don't text and drive. Additionally, I think addressing violence in our community with education and understanding what contributes to violence is important. And so the whole element of violence prevention, we don't deal with that a lot in the ED, but I think that's important and needs to be highlighted. Falls. We mentioned falls before. So I think promoting safe and supportive environments for people in their home is important.
Talk to families, talk to caregivers. Some traumas can't be prevented, unfortunately. But education is key. Outreach is key. And again, I have to emphasize the texting while driving. That one we see a lot, unfortunately, and that affects not only the person texting, but also other people that may not have been doing anything that needed to be prevented. Drunk driving, unfortunately, we still see a lot of those. And I've been seeing a lot of electric scooters without helmets. Those go a lot faster than people give themselves credit for. So that is another one.
Yeah, really, really good advice and good to keep in mind. I know it's hard to not glance at your phone when you're driving, but hearing it from you two is really good reminder that you don't want to end up in our ED, with an injury. You mentioned community outreach and working with people in the community and helping to avoid some of the traumas you see, such as fall prevention. Kate, I know that's a really big part of your role. Can you share more about some of the work that you do in our community?
I would love to. Thank you, Kristen. We have been teaching Stop the Bleed education to all the Valley Medical Center staff, and we have an ongoing relationship with the Renton School District, getting all the Stop the Bleed education to their educators. We're going to open it to the community, and you can find it on the trauma webpage. So it's free to the community. It's a lot like CPR in that you have some PowerPoint education, but then you have to get the hands-on. So we can only do a maximum of 15 in that class. Coming soon is going to be Trauma Nurses Talk Tough. It's about, helmet safety, drunk driving, a bunch of nursing stories for high schoolers and middle schoolers in the area. And also, I'm very excited for fall prevention. It's SAGES, and it's a fall education play by seniors for seniors, as falls is the number one mechanism of injury we see.
Really fantastic work and could be life-saving or life-changing in an emergency. So appreciate all of your work on that. You mentioned the trauma website. What types of resources can people find on our website if they want to learn more?
So on valleymed.org/trauma, and I'm sure you're going to have a link somewhere in this as well. Dr. Buck talked earlier about the trauma regions in Washington State, a little background on that, and there's a wonderful map so you can see exactly what he's talking about. We have outreach programs, drug and alcohol resources, sexual assault resources and information. We have fall education. In fact, our top mechanism of injuries, we have those listed with different education and outreach and some interviews. There are burn education as well. It's a wonderful, wonderful site to visit for yourself or your family. Speaking of falls, I know we've touched on this a lot. There is a huge fall packet that I created that can be printed out on there as well. And it has a whole bunch of different information for seniors and for families of seniors to help, because one of my favorite things to say is falling is not a normal part of aging. And if there's something the community took away, it would be that. So please go to our website and get some of the information that we have there. It's a really good source.
So I think that about comes to the end of our time together, but I just wanted to offer you one more opportunity. Is there anything we didn't talk about or anything you wish our listeners would know?
Well, thanks first, Kristen, for the opportunity for Kate and I to discuss this issue and raise awareness of trauma. What I would like listeners to know is that we should be proud of the state of Washington and its trauma system. We are fortunate to have a well-organized and relatively well-funded trauma system. And so citizens should trust that when care is needed for injuries or unexpected trauma, then the system is there to help you, whether it's a level 4 center in a rural area or a level 3 center in an urban area, or certainly the level 1 and 2 centers that make up our trauma system, including all the skilled workers, emergency nurses, emergency physicians, other practitioners, trauma surgeons, and all the teams that take care of patients from the point of injury to interventions to healing and rehabilitation if needed. Extremely valuable and honored to be part of that system.
Basically, have fun, be safe, and we are here for you if you need us.
With that, thank you so much, Dr. Cameron Buck and Kate Bendickson with Valley's Emergency Department and Level 3 Trauma Center. Really appreciate your time. I learned so much, and we will share those resources with the show notes. Thank you for joining us.
This has been We Are Valley, a podcast produced by Valley Medical Center in Renton, Washington, as a part of our mission to care for our community like family. If you liked this episode, be sure to subscribe to our feed for more great health content. And for more health resources or to find a provider, visit valleymed.org. Thank you for joining us.